The first half hour of this session will be for patients predominantly, and we know there's a lot of physicians that join us, and so they'll have a chance to answer their questions and ask their questions in the latter half of this hour. So let's get started. We want to talk to you about the goals of therapy. So when we're starting medication, it's important that both the doctor and the patient have goals of therapy. So the first goal that we have is really to induce remission. Treatment with inflammatory bowel disease is into two parts. It's inducing that remission, getting you better, and then maintenance of remission, keeping you better. And so the treatment algorithms, the medications that you're going to be on are going to be structured into those two forms. Induce remission, that is get you better, and then maintain remission or keep you better. Now, in keeping you better, you're going to be on medications for life. This is a disease that affects you for life, and so you're likely to be on long-term medications. The key for us in maintenance is to get you off of corticosteroids, keep you off corticosteroids and on a medication that'll keep you healthy. The third goal of treatment for us is to prevent complications. If we can treat you early, if we can get your disease under control, control the inflammation, you're going to have less complications. If you have less complications and your disease is under control, then you'll improve your quality of life. And that's the fourth goal that we have. Keep you healthy, keep you working, keep you at school, manage your quality of life. Ideally, we'd like to avoid surgery. Now, surgery can sometimes be a treatment for inflammatory bowel disease. We're aware of that. That's a good thing. But we want to prevent multiple surgeries. We want to use medications appropriately, early enough, so that you maintain remission, prevent complications, and therefore avoid your surgery. And finally, the last goal of treatment we call mucosal healing. We would like the lining of your intestine to be completely healed. We would like that the ulcerations of inflammatory bowel disease, the redness, the inflammation of inflammatory bowel disease is under control. And doctors call that mucosal healing. So let's review these goals of treatment. One is to induce remission, get you better. Two is to maintain remission, keep you better, and get you off of all corticosteroids and on a long-term maintenance medication that'll keep you healthy. By doing so, we'll prevent complications, we'll improve your quality of life, we'll avoid unnecessary surgery, and eventually we'll get to a place where the lining of your intestine is healed or mucosal healing. Those are our goals of therapy, and that is how we want the medication to work. If you think about the medication that we're going to use, you can think of it as an IBD treatment pyramid. At the bottom of that pyramid are the medications that are perhaps less intense, less strong, but also medications that have less side effects. And as we move up this pyramid, the medications tend to become stronger, tend to be used in more resistant cases, but also potentially come with more side effects. And so at the bottom of this pyramid is a drug called mesalamine. When mesalamine's not working, we'll move into antibiotics or probiotics. When those medications are not working, we'll move into corticosteroids. And when corticosteroids are not working, we'll move up to immunosuppressive agents. We have biologic agents. And at the top of the pyramid, we have surgery. So in general, while we may skip some of these levels, or we may advance quickly through this pyramid, doctors are going to follow this pyramid of treatment. And your doctors who treat IBD will know all the medications in this treatment pyramid and be using this pyramid to guide them. So now let's move forward to the next topic, and we'll discuss some of these treatment medications in more detail. And so I'm going to turn to Dr. Leo Deelman, who's an associate professor at the University of Alberta, and he's going to talk to you specifically about the treatments in ulcerative colitis in more detail. Dr. Deelman?
Well, thank you, Richard. And thanks for this opportunity to talk to you. And ulcerative colitis, you may recall from the last time, is different from Crohn's disease, and I think it's important to recapitulate that again, that it's confined to the colon, the large bowel, and it's more of a superficial disease than Crohn's disease in general. So, and that actually goes with the treatment that you would give for these patients. For instance, Richard just mentioned the role of mesalamine, and you may know them under medication names of Pentasa, Salfalk, Azacol. Those are tablets that are having an effect in the lumen, and lumen meaning the bowel lining and the whatever is in there. They have anti-inflammatory effects, have really high concentrations to get their anti-inflammatory effect there. But it's superficial disease, so that's important to get high concentration right in the lumen. But also, and there comes the difference in with Crohn's disease, it is not superficial disease, and the inflammation can be very well treated with something called enemas, which means that you give something into the rectum or beyond, into the left side of the colon, and this called an enema, or a suppository where you just get a high concentration of this medication into the rectum. So our first line treatment is that you use these medications, try to use them because that's the bottom of the pyramid, and try to use them maximally. So people frequently say, oh, well, this medication, it doesn't work anymore. You got to make sure that you have adequate amounts of this medication on board before you're taking the next step. Because every step you take into this triangle means that you go into potentially more toxic therapy. So frequently when you have a flare of ulcerative colitis, we'll give you those tablets forms we call mesalamine, and frequently combined, depending on how extensive your disease is, with either a suppository if it's just in the rectum, or if it's further than that and you have in the left side colon to give you an enema. Now that being said, even if you have a disease all the way to the colon, there's still a place for topical therapy like enemas and suppositories, because what people frequently complain about is the high amount of urgency, the urge to go to the bathroom, we do small amounts of stool or nothing at all, and this is one of the most debilitating symptoms of ulcerative colitis. So I always do both. Further up, after the mesalamine doesn't work anymore, then you have to think about other therapies. Frequently we think about, oh well, now it's time for corticosteroids. But you shouldn't forget that there is still a place, and we can talk about this a little bit later, for probiotics, and not all probiotics work, but some of them have been done in a clinical trial. And there is a place for that, to give this in addition to mesalamine and get you into a clinical response, meaning you're getting better or you get into remission. Now, if you move up in the triangle here, then you can see that the disease gets so bad that you can't, you have still symptoms after using maximal dose of the mesalamine. You require corticosteroids. And corticosteroids, a good therapy to keep the inflammation down, it works directly. And if corticosteroids do not work, or you're becoming dependent on it, because remember what we said in the beginning, we do not want you to be on long-term corticosteroids. These diseases are not, you don't want to treat the disease for the first 6 months. This is a lifelong disease. So it's very important to get the corticosteroids out of the picture. You need them whenever you need them, but you kind of find a backup plan for your long-term treatment. And that's where you're thinking, I got to think about immunosuppressives. What are those? Those are the medication called Imuran, 6-MP or pyrinethol, or methotrexate, although methotrexate doesn't get used very often in ulcerative colitis. Once you're on this medication, we'll talk a little bit later on what this means for monitoring, but you are in the triangle with that you have to monitor for side effects. Now, immunosuppressives is not a drug to treat the disease. It takes 3 months before it works, but it's a disease that keeps you better, that induces remission, that you have no symptoms anymore. That is important to remember about immunosuppressants. When immunosuppressants fail, again, we move one step up in the triangle. You're looking at biologic. And what we mean by that, these are therapies such as Remicade and Humira. One is giving as an IV, intravenous. You go to a clinic and you have to have an infusion every 8 weeks or every 4 weeks. Or you get Humira, which is a treatment where you can give that by injection, but actually something you can do yourself, either every 2 weeks or every week, depending on what your needs are. And do not forget on the very top of it, an ulcer colitis, if you have to go surgery, frequently means that you have to remove the entire colon. So moving a part of the colon if you have ulcer colitis means that you get a disease back and whatever you leave behind. So that's an important thing and a big distinguishing feature between the surgery for ulcer colitis or Crohn's disease. But I think that'd be for some more discussion later.
Yeah, next month we have a session on surgery, so
that's
right, a good segue into that.
Yeah. So the step-up therapy, as I just told you, so to recapitulate, you come there with your first flare, the doctor will likely prescribe you mesalamine with these tablets and combined with enemas. But you come back and you have a second flare, particularly in a short period of time, your doctor should think about, maybe I just need to think about how to prevent the next flare and prevent you from having to go onto therapies such as corticosteroids, with like prednisone. And then it's time to think about immunosuppressive medication. And this immunosuppressive medication may keep you into remission in about 50% of cases in ulcerative colitis. If you come to a second and you come to a third flare and you're on immunosuppressant therapy, then obviously it becomes clear that those immunosuppressant therapies by itself do not work. And then you've got to think about the step up to anti-TNF. So that's basically the step-up approach for ulcerative colitis.
Well, thank you, Dr. Dielman. So we've covered the treatment pyramid that we use for ulcerative colitis. We've covered the step-up approach that we generally use for ulcerative colitis. And so now I'm going to ask Dr. Karen Croker, who's an assistant professor in the Division of Gastroenterology at the University of Alberta, to outline treatment for Crohn's disease. Dr. Croker?
Okay, thank you. So I think the first thing we want to talk about when we talk about Crohn's disease is that there's 3 types of disease behavior that we talk about. And so there's inflammatory disease, and that means it's inflammation and it should respond to medications that reduce inflammation. And so for people with inflammatory type of Crohn's disease, we follow the treatment pyramid. So we'll go through that in the upcoming slides. However, over time, and often people can sometimes develop a type of disease called stricturing, and that means they've developed a narrowing of the bowel. And so that means if it gets narrowed, then when luminal contents are trying to go through, that things can actually get stuck along the GI tract and giving symptoms like obstruction or bloating, things like that. And so then often we treat that, we think that stricturing is actually partly inflammation, but it can also be partly scarring. And so medicines are really good at treating inflammation, but they're terrible at treating scar. And so we usually follow the treatment pyramid to see if we can get through that. We often use a low-fiber diet so that you don't have a lot of things like popcorn getting stuck or lots of seeds and things, because if the narrowing is kind of fixed, it actually can get just stuck, and it's not really because it's too narrow, it's just that you can't tolerate high-fiber foods. And then the last thing is if those are narrowings that they will persist and don't respond to medicines or the diet. Sometimes we can use a scope to stretch open those narrowings, called the endoscopic treatment, and we use a balloon to stretch it. Or else if we can't get it better with that, or if it's a long stricture, then sometimes we need surgeries to fix that. The third type of disease that you can sometimes get is when your the ulcers in your bowel are so deep, they actually cause penetrating disease. And penetrating diseases lead to things like fistulas and abscesses. And so a collection of pus is what an abscess is, and so you need antibiotics. Often we use TNF medications, those biologic medications a little earlier, and we use immunosuppressives. And for abscesses, sometimes they need to be drained either surgically or with radiology tests. And so that's something to be important to note about. So next I want to talk about the bottom of the treatment pyramid for Crohn's. So for Crohn's disease, we always start once again with the bottom of the treatment pyramid. So mesalamine isn't actually used that much for Crohn's anymore, but there is still a place for it, probably within mild disease, and sometimes for preventing Crohn's from coming back after you've had a surgery. But it's really not for anything moderate or severe disease. When you've antibiotics that we talk about at the second part of the pyramid is actually really important for treatment of fistulizing disease as well as the treatment of abscesses. And so those are actually very important. And then if you actually have a flare of your Crohn's disease, we actually usually use corticosteroids to get you better. But that's the thing, it's an induction medicine only. And we usually start with prednisone 40 to 60 milligrams per day, and we taper it really slowly over months, not over weeks. Sometimes if your disease is just in the end part of your terminal, in your ileum, your small intestine, we can use a medication called budesonide, which is similar to prednisone. It's actually a type of prednisone, but it actually has less side effects. but it's actually a little less powerful as well. So it's a little less chance that it'll get you better. And the medicines are a lot more expensive than the prednisone is. And so that's something to keep in mind. Next, though, the thing is, once you've gone on to corticosteroids, you actually need something to keep you better. So you need an immunosuppressive medication, like at the middle of the pyramid, like azathioprine, which we dose by weight, 6-MP, which we also dose by weight, or methotrexate. So methotrexate is an interesting medicine because it actually is only given once a week. And you actually always need to be on folic acid when you're on that medications. The other thing about these immunosuppressive medications that's really important to know is that all of these medications require monitoring. So the monitoring that you require is usually blood tests to look for your white cell counts or your blood counts, and also to look at your liver tests. And so both of these medications actually can affect those things, and so it actually makes it so that you might need to check for that. Once you've been on immunosuppressives, and if you once again flare your disease, then often we move up to biologic therapy. So the infliximab, adalimumab that Dr. Dielman talked about in ulcerative colitis, and we use those same medicines, and they can both be used to induce remission, to get you better, as well as to keep you better. So initially, for both those medicines, we actually give you kind of a loading dose, a higher dose up front, and then over time, it usually, for the adalimumab, is with the injection, it's every 2 weeks, and with the infliximab, it's every 8 weeks. And then at the top, we're talking about surgery, but I'm just going to tell you that we're going to talk about that next month, so I didn't prepare any slides on that. So this is kind of the step-up treatment approach that we use for Crohn's disease. So those triangles actually represent corticosteroids. So when you first are sick, usually we use prednisone right away to get you better, and then you're going to be on an immunosuppressive like the Imuran, the 6-MP, or else the methotrexate. And then if you actually flare again, especially within a year of your Crohn's disease and you're taking your medications, then we actually would usually move up the treatment pyramid and go on to the anti-TNF medications. Sometimes when people flare and it's 6 years out and since your flare, we might actually just try prednisone to get you better and see if we can just leave you on that immunosuppressives. But if it's really short interval in between, it's really important that we actually don't just leave you on the same medicines because they're clearly not working anymore. Do you want to do the override or shall I?
Go ahead, Dr. Coker.
So I guess one thing is that you remember for our treatment pyramid, you have to remember the goals of treatment. So Dr. Fedoruk talked about those at the beginning. So induce remission, get you better, maintain remission, and then we want to usually try to avoid surgery. We want to improve your quality of life. We want to avoid complications. And
mucosal healing.
And now we think we want to heal your mucosa. So for a long time, we didn't know that that was important, but more and more the science that comes out shows that this is actually important for us, important and marked so that we can avoid complication. So for ulcerative colitis, like Dr. Dielman talked about, mesalamine still remains the mainstay of treatment, and that topical treatment, that rectal therapy that he talked about, those enemas and the suppositories, well, most people don't like to use those medications once they realize that they actually make a difference. It's actually really important to use to get you better. It really helps supports with those urgency. Nobody likes to have incontinence, and so that's what they're used for. For Crohn's disease, we usually require immunosuppressives or biologics, and we have to keep in mind the type of the disease. Is it inflammatory? Is it stricturing? Or do you actually have penetrating disease? And so in the end, we follow the treatment pyramid, and we use a step-up approach.
All right, thank you. So now we have time for questions. So this is for all of you from across Canada. Please type in your questions. You've got 2 gastroenterologists, 3 if you count myself, that can answer your questions related to your medication. So we do have some questions coming in, and I'll field these questions. And so the first question relates to steroids, corticosteroids. You both, Dr. Dielman, Dr. Coker, have talked about corticosteroids. And the question is, I get a lot of side effects when I start my corticosteroids, but yet my doctor continues to put me on it when my disease flares. So I think the question is there another drug? Is there something else you can use other than corticosteroids to get me better quicker? Dr. Coker, did you want to try and answer that question?
Actually, steroids is actually still a really good medicine to get you better, and we understand that many people have side effects. And so to some degree, it depends on the severity of the side effects and what else we can do. The important thing is that we actually don't leave you on steroids long term, and that we follow that treatment pyramid so that we can actually avoid the use of steroids. However, we still think that it's one of the best medications that we can use. If you have milder disease, especially with ulcerative colitis, sometimes we can get you better with antibiotics or probiotics, as well as the higher dose mesalamine. But often when you're really sick, you actually do require steroids. And sometimes if you're sick and admitted to hospital, we have to give you IV steroids, and those tend to work the quickest.
But can we stop the steroids after a couple of days, or do we need to continue them? You said weeks.
I said weeks, actually months. And so what it is that in some other diseases like COPD or asthma, things like that, we can use a short course of corticosteroids. But the inflammation in inflammatory bowel disease doesn't respond well to those short courses. You actually need to have a good dose and slowly taper it. And once you've been on prednisone for more than 2 weeks, you actually have to really be careful about tapering your steroids slow enough, because your adrenal glands actually make a steroid that is very similar. And actually they go to sleep when you start taking the medicines for long term, because you're actually taking more than that. And they're actually really important for you to slowly taper them off, in part so that your adrenal glands wake up and so that you don't get into problems with that, because you actually need that steroid medication to stay alive.
Can I come in with ulcerative colitis? Because typically people that getting more and more corticosteroids from their family physician for ulcerative colitis, I really want to emphasize the point that, as I said in the beginning of my slides, sometimes you really need to max out what you have. Max out that you really are not like having low dose, like even two grams of mesalamine, that you really need to up the therapy.
Right, by maxing out, you mean put you on the maximum dose of the mesalamine.
And then the next thing is that we can talk about this another time in another session, but the role of probiotics. There is now studies have been done where people that are failing those therapies do not necessarily have to go on corticosteroids as long as their disease is not really bad.
So, Dr. Dielman, what would be the maximum dose, appropriate maximum dose for mesalamine?
Well, I think that the maximum from a dose of mesalamine should be anywhere between 3 and 4 grams a day.
So when you're having a flare, if you're on a lower dose, go up to that higher dose before steroids.
And for instance, add an enema to it.
Right. And adding the enema on top of the oral pills to take both?
Yeah, I will take both. Yeah, and then the patient typically stops the enemas after like a month, and then see if the pills itself will just carry the disease into remission.
And that's an ulcerative colitis. And Dr. Coker, what about in Crohn's disease, the mesalamine and the enemas? Do you use those as well?
No, remember at the bottom of the pyramid, we think it only works for mild disease, and so, sometimes for rectal Crohn's disease, I sometimes will use suppositories, but for the most part, it's usually not strong enough.
Right. So mesalamines we use more often for ulcerative colitis and a lot less often for Crohn's disease. Okay, good. Thank you. So let's answer another question here from across Canada. I have Crohn's disease for 20 years, and I've been on Imuran for the last 15 years, and I'm worried about long-term side effects. Now that's important. We've all mentioned risk and benefit and side effects. So Dr. Dielman, do you want to talk about what we think about the long-term side effects of Imuran?
Well, first of all, I mean, Imuran is an immunosuppressive drug, and that means that you have a higher risk for infection, and those things need to be monitored. And as Dr. Croker already mentioned, you need to do your blood work and on a regular basis and make sure that your white cell count doesn't drop below a critical level that you be more susceptible for those infections. But but on top of this, and I think what people really mean, they have heard about stuff like the risk of cancer or lymphomas. That risk is indeed there on those therapies. But it's not like, oh, well, somebody was even thinking some kind of a 50-50 chance on getting this long term. I mean, for instance, there is something we call a lymphoma, it's hepatosplenic T-cell lymphoma. That risk, to give you an idea, is 4 out of 10,000. And if your disease is so bad that you need immunosuppressive therapy, then I think the benefit versus the risk tips over.
So four out of 10,000 might sound like a big number to me. What would that be relative to me having a car accident, for instance? What's the chance of having a car accident out of 10,000?
I don't know how you drive your car.
That's a good point, Dr. Dielman.
So over to you.
But I think the risks of having a car accident in any given year for the average person is somewhere in the range of 100 or 200 per 10,000, whereas the risk of getting this rare disease is 4 in 10,000. So we take many bigger risks during our day and during our life than would come up with this type of medication. Dr. Coker?
Could I mention something else? The one other thing I think we have to remember is that with immunosuppression like Imuran is that you actually have to be careful about your risk of skin cancer. And so the one thing you should always be careful about is wearing sunscreen, wearing a hat, and trying to avoid the sun. It'd be important for you actually to see your family doctor to have them examine your skin so you don't have any new moles and so that sort of thing. And the other thing is that it's also important for you to do all the other regular monitoring. I don't know if this person is a woman or not, but they should be having their pap smears and things like that and following up with all of those things that those increased viral infection risks that you have with Imuran.
Right. So there's things that when you're on these drugs, you need to follow up with your doctor, and that's a really important point. So let's go on to some of the other questions. There's a question of diet and inflammatory bowel disease. Dr. Dielman, a quick answer. Changing your diet, is that going to cure your disease?
That's why he's asking me for a quick answer, because I can go on for half an hour on this.
We want to, yes, less than half an hour would be good.
We're doing actually a research study right now on the role of diet, particularly in osteocolitis. But a very general answer is, for instance, if you're known with a narrowing of your bowel, your stricture, you have to be careful with a diet full of fibers, something that will otherwise cause an obstruction. But in general, is what I always tell people is to eat healthy, that you don't, and that you eat enough vegetables, that you eat enough berries, which has all kinds of products in there that are anti-inflammatory, and that you eat, and that you fibers that you take.
So a healthy diet is important, and the diet, changing your diet's not going to cure your Crohn's disease.
No, it's not curing. Absolutely not. No.
Yeah.
No.
Dr. Coker, another question here. I was recently diagnosed with ulcerative colitis during a hospital admission, but they put me on Imuran right away. So do you want to talk a little bit about how doctors think about high-risk patients and low-risk patients?
Sure. So I think whenever we admit somebody to hospital, and they actually, usually, because a lot of people actually can get treatment for their ulcerative colitis or their Crohn's disease as outpatients. When you get admitted to hospital, you actually fit into a higher risk category. And usually because your disease is a little more on the severe side. And so if they chose to give you azathioprine in addition to the Salifolk, I think the thought process is that they didn't believe the Salifolk would be effective. And so I don't know if they were on Salifolk before or not, and they thought it wasn't going to be effective. But it's also, if they might have thought you had Crohn's colitis, or it might have been possibly, they would have thought more likely to use azathioprine. Or really if they were considering that they might even need to go up the next step to do TNF therapy to give you that chance to avoid that higher escalation. And so I think part of the question is whether or not they won't have to stay on the azathioprine forever. And I would say probably, but I think it's a little too early to know. And I think over time that would be something that you'd have to discuss with your doctor. But usually once you reach a treatment pyramid, a higher point in a treatment pyramid, you usually can't go down. And so
and I think it's important to tell both patients and doctors that that treatment pyramid, doctors can, depending upon where your disease is, how severe it is, doctors can advance up that treatment pyramid quite quickly. You don't have to stay at one level for a long period of time. It's the severity of the disease that will determine where you might enter in or how quickly you advance up.
That's right.
Yeah. Let's do another question here. My gastroenterologist prescribed mesalamine enemas, in this case a Salifolk enema for my flare, but Dr. Dielman, I can't hold them. It doesn't stay in. So do you have any tricks of the trade to help me in that?
Well, first of all, I tell people, like, you keep these enemas and you keep them refrigerated. And some people just don't realize that if you have taken enema direct straight out of the refrigerator and trying to put it into yourself, then
cold enema,
that's a very difficult thing to hold for
anybody.
So
you want to warm up your enema.
So you have to warm up your enema.
Hug your enema.
Hug your enema, and then, because if these enemas cannot be held in, of course you lose all your treatment effects.
Right. So it's contact time.
It's contact time.
Helps.
So you need to take the time to warm it up, and also need the time when you give these enemas to yourself, that you can hold them, that you roll in different positions, that you kind of give it the time to do its effect.
So perhaps maybe at bedtime when you're less.
When you're not busy or you're not stressed, and those things.
So the morning time might not be a good time for an enema if you're trying to rush off to work and trying to hold it at the same time.
Yeah, unless you find out that your nighttime enemas by itself don't work. So you have to do it twice a day.
Dr. Dielman, Would you ever recommend just giving half of that enema? Because sometimes the volume that they can hold in, if they can hold in just half of it.
Totally.
And sometimes I actually would say also to use the suppositories if they can hold on.
Yeah, so in other words, if the real effect is, well, people have all the complaints about the urgency is in the rectum. So sometimes people then cannot have enema, they can hold them. Suppositories work better. Really good.
And do you ever use cortifoam if they can't hold in their Salifolk?
Yes, I do. So you can switch between them because you have Salifolk enemas, you have cortifoam enemas, corticosteroid, otherwise. They work just evenly well. And some people have great effect with corticosteroid enemas, other ones do really well on Salifolk. Although I always tend to use Salifolk first just because of the potential side effects.
Yeah, I agree.
Okay, so a question, interestingly, this is a question from Vivian in Rome, Italy. Hi, Vivian, how are you? Good to see you joined in. It's late, close to midnight there, so... Vivian's question is, I have Crohn's disease and have been on Remicade and Imuran for the past 5 years with no flares for 2 years. When can I stop my medications? So maybe Dr. Croker, you want to talk about this because you mentioned that the medications generally can't be stopped.
That's right. So it's actually a really interesting question because actually you're on combination therapy, which we actually believe, and I didn't talk about this in the treatment pyramid, is that we believe combination therapy is superior to actually monotherapy. So Remicade plus Imuran is better than Remicade alone or Imuran alone. And so the thing about it is we actually don't know the stopping rule. So recently, and every time we go to different meetings, people have tried these different studies to see whether or not we can stop one or the other. Currently, the jury is a little bit out. And so I think if I were you, I would just stay on both of them and wait till somebody else to test the theory to see which one you can stop. And once we have more information, it might be something that we would consider in the future. But for now, as long as you're not experiencing side effects from either thing and you're able to stay in remission, it is your best chance to stay better.
It's one of our goals of therapy, maintenance of remission off corticosteroids. And because this is a lifelong disease, we think that lifelong medication is probably needed.
Mm-hmm.
Right.
Yeah.
Okay, another question here about how do you decide whether you use azathioprine or 6-MP or methotrexate? We've mentioned those are 3 immunosuppressive drugs, and in our pyramid treatment, we have immunosuppressive drugs, and now there's 3 of them. So Dr. Dealman, do you have any magic on when you use one versus the other?
Well, first of all, azathioprine and 6-MP are tablet forms. So it's way easier for a patient to try those first, rather than methotrexate, which we frequently use as an injection. Mm-hmm. So it also depends on availability between, for instance, azathioprine is used very much here in Canada, versus 6-MP is used a lot in the United States. And I worked in the United States, so I have first-line experience on that.
Do you think those drugs are about the same?
I think they're about. I think this effectiveness is about the same. Mm-hmm. But what you may find that some people have side effects on one drug, right. As long as they don't have what we call acute pancreatitis, right. They can be switched over to the other one. Okay. Now, the role of methotrexate depends what you're talking about. That would say more effective for Crohn's disease than ulcerative colitis. And some people just that have severe side effects on right. Those 2 medications, azathioprine and 6-MP, can be switched over. Right. So I'm using it more of a second-line therapy mm-hmm. versus the first line.
And you want to talk a little bit about methotrexate and the woman who wants to get pregnant?
Yeah, so methotrexate is a very important point that you just raised. So you do not want to have a woman on methotrexate when she becomes pregnant, and you never know. I mean, ideally, people will talk about it and when they come to see you, but frequently people get pregnant on their medication, mm-hmm. and if you happen to be on methotrexate, that actually does have potentially bad effects on pregnancy okay. and fetal malformation and all
right.
these things.
So methotrexate's not a drug you want to use.
I will not use it in
planning pregnancy.
No, absolutely not.
Okay, good point. So another question about inflammatory bowel disease in pregnancy, and we are going to have a whole session on pregnancy and inflammatory bowel disease, but maybe Dr. Croker, I'll have you answer this question. It says, I am using Remicade, which is the name for infliximab, but I'm worried about drug complications on my fetus. Should I stop the drug? So a complex question, but why don't you try
So I think actually the good thing about Remicade is it's actually a class B. So when you look at medications and how they're classified in pregnancy, there's class A, B, C, and D, and X. And so methotrexate is one of the only medications that's actually an X. So we actually say it's teratogenic and you should never take it in pregnancy. But Remicade actually, at least for the first 2 trimesters, is actually a class B, which is one of the safest medications that we have. And so actually I wouldn't stop it. The thing about it is that you need to talk to your doctor about the timing. So we often try to hold the dose just before you're getting it delivered because we know that actually it gets transferred across the placenta, but really only in the 3rd trimester. And so we like to try it so you actually, when you're delivering, you're probably at your trough level is a low level, and you need a dose pretty soon after you deliver just to reduce the exposure to the fetus. And so there's many people that have actually had babies or healthy babies on Remicade, and we don't see any signals in terms of bad things to the fetus. However, those babies aren't very old, and so we don't know the long-term side effects of it, whether or not it will mean that we can use that medication and whether or not we'd be able to use it if your baby had Crohn's disease down the road, or maybe they'd be more responsive to it. So it's actually hard to know. But for now, and based upon all the evidence that we have, we believe it's safe. And it's actually the most important thing in pregnancy is for you to try and stay in remission. So if you needed Remicade to get better, you should stay on it.
So a mother going into pregnancy should be in remission. That's really important and healthy for the baby.
Yeah.
And I think in terms of the timing of your doses right before you deliver, you should probably try and time it so that you actually are ready for a dose right when you deliver. And so that's something that you should talk to your GI about to make sure that timing is good. And
I think another important aspect here is for the mother who has Crohn's disease, who is pregnant, is not to have a flare. Mm-hmm. And because of that, we would want that mother to remain on their medications which, after discussion with your doctor, are safe for that baby and that pregnancy so that you don't flare.
Well, I think in general also, and it's a very general point, is that as a patient you shouldn't stop your medication without consulting the physician. Yeah. We see this over and over again. People think, well, I know I feel great, so why would I take all these pills? And you know, then you're really playing with your disease and playing with complications.
Right, that's one of the cardinal goals of treatment is maintenance of remission, and maintenance requires long-term medication.
Right. Yeah.
Okay, Dr. Coker, you talked about Remicade, but there's another drug called Humira, which is also a biologic. For pregnancy, would you see the same on-off stopping rules applying?
So it's a little more complex with Humira just because we usually give it every 2 weeks, so it's harder for you to hold it before. But we actually do usually hold it a number of weeks before you deliver. But once again, it's a class B, a safe drug during the first 2 trimesters for sure. And there's been many babies that have been born on Humira as well, and it has the same safety profile.
Right. Okay, let's move to another question about Imuran. Patients on Imuran doing well, in remission, should they stop it? Can they back off on the dose? Can they take less? Dr. Dielman?
Well, it all depends. I mean, typically, if you're on Imuran, you shouldn't stop it because the reason why you're on Imuran is the reason that before you got Imuran, you were sick all the time. Mm-hmm. So that is my first thing. If you're doing really well on that dose of Imuran and you have no side effects and your liver functions are good and your white cell count are good, why change and winning team? So I will keep it on, and I'll keep on the same dose. I really don't think I would lower the dose. I would only lower the dose if I get indications that there are side effects or that the blood work doesn't look that good.
So long-term maintenance Imuran is a good thing for maintenance of disease.
That's right.
There's another question about Imuran. Obviously, lots of people are out there on Imuran. It says, I'm on Imuran and keeping my blood tests normal, but I've got bad joint pain. And we know joint pain is arthritis, goes along with inflammatory bowel disease. Is there another option? And maybe I'll try and answer this question.
Good, you're going to take one.
I'll take one question. The arthritis that goes with inflammatory bowel disease is common. And often the Imuran brings it under control, but sometimes it doesn't. And this is where your doctor might choose to switch you to methotrexate, which can treat both the bowel disease and the arthritis. Your doctor may also choose to put you on an anti-inflammatory drug, one that's used for arthritis, like Motrin or like Celebrex. Those are 2 examples, along with your Imuran to control your arthritis as well as treat your inflammatory bowel disease. So it's more complex, but you do need to see your doctor so that they can organize those things for you. Another question, Dr. Croker, before we go to the doc talk that we want to get to, is patients were asking us about microscopic colitis. And is microscopic colitis the same as Crohn's colitis, ulcerative colitis? And or do we use the same treatments?
So microscopic colitis actually means that when we actually do endoscopically, we look and the colon looks normal. But when we take biopsies, they see changes under the microscope, which is why it's called microscopic. And so the treatments, we don't think it's the same thing because first of all, it does cause diarrhea, chronic diarrhea. However, it can be associated with things like celiac disease. And so if you have celiac, we should treat the celiac disease. Or it can be associated with a number of medications. But we don't think it has a long-term chances of having complications. And so the medications sometimes are similar, but they're not always. And so it's actually a little harder to explain.
So we're thinking of it as a different disease, and it's not really under the category of inflammatory bowel disease.
Mm-hmm.
Okay, let's move on. We've always divided this program into a section for the patients and now a section for doctors. We're going to talk in a bit more detail about the medications. We call this Doc Talk. We want the patients out there to stay with us. We want you to continue sending in your questions that may come up, but we also give the physicians an opportunity to dial in their questions that they may have. So let's move on to two of these algorithms that you've seen before. So treatment pyramid for the physicians. Again, we have mesalamine at the base, where we would use this mainly for ulcerative colitis, rarely for Crohn's disease. We've got antibiotics and probiotics. We add mainly if you have colitic aspects, so colonic involvement of your disease. Moving on to corticosteroids. Here is where appropriate dose and appropriate duration. 40 milligrams as a starting dose, tapering by 5 milligrams each week to 20 milligrams and by 2.5 milligrams each week to off. That gives you about 12 weeks of corticosteroids. That's what it takes to get that inflammatory disease under control. Shorter durations, lower doses will often just mask the disease for a short period of time, and then we see rebound flares. So those high doses for those extended periods of time to bring the disease under control. In this treatment pyramid, immunosuppressive agents, again, dose is important for us. Imuran, 2.5 milligrams per kilogram per day, 6-mercaptopurine, 1.5 milligrams per kilogram per day, methotrexate at 25 milligrams per week. These are doses that we need to memorize. We need to remember these because lesser doses are not effective, and you'll often have a patient that gets into resistance with those lesser doses. As we move to biologics, we've got two currently on the market. There's more that are going to be available to us later this year in 2013. Right now we've got Humira, which is adalimumab, and we've got Remicade, which is infliximab. Both of these medications for Crohn's disease, both of these medications for ulcerative colitis, and in my opinion, both of these medications similarly effective for ulcerative colitis and Crohn's disease. But again, using the right dose, 5 milligrams per kilogram every 8 weeks of Remicade. When using Humira, it's 160 milligram induction, then 80 milligram, then 40 milligrams every other week. Again, knowing those recipes, knowing those doses are really important. You also need to know that I think working in conjunction with a gastroenterologist, a family practitioner, and a surgeon and someone who has inflammatory bowel disease is incredibly important. These diseases require long-term maintenance, follow-up. These diseases require adjustment of treatment, doses, and medication. And these diseases often require surgical intervention. And so you need a team of people to be there managing your disease. And don't hesitate to contact any one of us if you have questions about these doses or about the patients that are out there using these medications. So maybe I'll turn over to Dr. Dielman. And Dr. Dielman, maybe go through this step-up treatment approach that we touched on briefly, how you might advise a physician to use this, and what you want them to do in follow-up.
So what I wanted to do is, first of all, I recognize that the treatment for ulcerative colitis, first-line treatment always starts with mesalamine. Mesalamine in the oral form, in the pill form, should be dosed adequately. And if somebody has a flare of ulcerative colitis, that dose should be about 3 grams, sometimes up to 4 grams a day, and frequently in combination with topical therapy, since this ulcerative colitis is a more superficial disease, enemas and suppositories will work better. If you have a patient who comes to you with frequent urgency but still has like solid stool, that patient with a known ulcerative colitis likely has a proctitis, and you can try suppositories as a therapy to get that patient into remission. Versus someone who has diarrhea and blood in the stool likely has a more extensive disease. Left-sided colitis can be treated with enemas in combination with oral mesalamine. Now, if the patient comes back, and I refer to this particular diagram, with another flare, and despite adequate doses of these therapies, then maybe it's time to think about something else, and a step-up therapy. Now, we put on here immunosuppressive, such as azathioprine and 6-MP for ulcerative colitis, but you also need to know that there is, if patient currently able to afford it, there's a place for probiotics, and that's something that comes more and more into our awareness. That's something we can do before giving corticosteroids. Now, the point I want to make before we go into corticosteroids is frequently I see people just giving corticosteroids right away from the bat, and that's not always the best thing to do. Optimize your 5-ASA therapy before calling it and then going to the higher dose, because once you're on immunosuppressive therapy, you're on it. You're on it for a long time. You're not something like you're going to try this for a few months. It takes 3 months before it to work, so you have to have some kind of therapy.
Right, so maximize your mesalamine to that 4 gram
You might
dose.
even have to have, at that moment, you use corticosteroids, and then you hope to stop the corticosteroids, so the immunosuppressors, hopefully they will have a corticosteroid sparing effect.
Right.
And of course, lastly, you have people that are, despite adequate doses of immunosuppressors, will still flare. And those people need to be considered for anti-TNF or even surgery.
And your treatment for steroids is, as I mentioned, you would use that 40 milligrams tapering?
Very important. I'm glad you mentioned that, because it's important to do this slowly and to slowly taper. So you start at 40 milligrams and you taper with 5 milligrams per week till you get a dose of 20 milligrams, and then you taper 2.5 milligrams per week. Because the problem that we frequently have is that people come off with these rapidly tapering of corticosteroid. We never know if this is an adequate tapering dose. We always don't have to do it again, exposing the patient to longer periods of corticosteroids, because the consequence of that is that we will really need to know if they are corticosteroid dependent, they are going on immunosuppressive.
Right.
And that's a big step.
Right.
So you want to
that
avoid
proper recipe, the proper dosing is really important.
And another thing I want to really mention, and we did mention it the last time here as well, is that people that when you have a flare of ulcerative colitis, rule out that you have infections, that you have a Salmonella, Shigella, Clostridium difficile.
Rule out infection first.
Right, rule infection first. So it would really be helpful if you refer a patient with a flaring ulcerative colitis to us to get all these things done. So we don't treating someone with prednisone who actually has a C. diff infection.
And we covered that in our webinar last month, and it's now on the website IBDClinics.ca. But we want the family doctor to have done some blood tests, CBC, CRP, and some stool cultures and C. diff toxin assays.
Yes.
Right. Okay. So let's move on. Our time is moving on. We want to move on to Crohn's. And Dr. Croker, why don't you take us through what's important for the referring physician to know about treatment of Crohn's disease?
Okay, thank you. So I think what it is the step-up treatment for Crohn's disease. For most people with Crohn's disease, once they have an established diagnosis, are at least going to be on immunosuppressive. So with our first flare, we almost always start an immunosuppressive just because mesalamine really hasn't been shown to be that effective in Crohn's disease, except for very mild disease. And so once you've been on a tapering course of corticosteroids and you're on immunosuppression, we actually really have to think about when you flare, what should we do next? And so if it's been a long time, it's possible that we could maybe try another course of corticosteroids to induce remission. But if it's actually a year or less, for sure, then we actually need to go up the pyramid. And so the next thing we actually have is anti-TNF therapy, so the Humira or adalimumab or Remicade infliximab. And so those medicines are very effective for inducing remission. And you can see that once again, we use triple therapy to induce remission. So we'd keep you on the Imuran or the methotrexate, but we'd actually add in a tapering course of corticosteroids as well as we'd add TNF. You've got to remember that it does a little bit depend on the flaring. If it's flaring, if you have perianal disease, we might need to add antibiotics in there. If you're flaring your perianal disease, you might actually need to have an MRI to look for abscesses, or we might need to send you to surgery to do an EUA, and that's one of the things we'll talk about next time with that perianal fistulizing disease, which is really important. And so the other thing is that the other way people flare is often with an obstruction kind of symptoms. And so people that have stricturing or narrowing type disease, when they get obstructed, it's actually important for them to go on a clear fluid diet. And if they still can't maintain it, they need to come in, because often we need to give them IV fluids, put an NG tube down and get them to open that obstruction. Because even if you need to have surgery to cut out some narrowing of it, it's better for people to go into surgery without having an acute obstruction, because it makes the operation that much better for the patient as well as for the surgeon.
Okay, so excellent coverage of those two diseases. Let's answer some of the questions that are coming up now. Dr. Croker, my patient's on Imuran. What do you want me to follow as a family practitioner?
So I guess what it is when we put people on Imuran, first of all, we usually put people on an escalating dose because people might not metabolize the drug the same. And the two side effects that we're looking for is actually usually the decrease in your white cell count. And so we usually tolerate white cell counts going as low as 3. Lower than 3, we start to adjust the dose. And then we also follow liver enzymes. So liver enzymes, I think one of the family doctors that tuned in is worried about hepatitis. And how much do we worry about? So there's a couple of reasons our liver enzymes can go up. One is because of the dose. Another thing is they could have an intercurrent infection, something like a mononucleosis, which can cause their liver enzymes to go up. So if their liver enzymes are less than 2 times the upper limit of normal, I actually usually don't do a lot. I usually just repeat them to see if it's changed, because they might just have an intercurrent virus. If, however, they're greater than 2 times the upper limit of normal, it's actually important to probably hold it, especially if they go really high. And so usually it's a hepatitis picture, but every once in a while you can get a cholestatic picture with the elevated ALK-Phos. And so it's actually really important to look at those. And if you stop it, and you got to remember that Imuran takes months to work, so holding it for a few days and repeating it is not a bad thing to do. And if you're not sure, you can always call us. Because usually when we give people a requisition to have their blood work checked, we follow those things along with you. So the requisition would have both us and you copied on it. And so that's part of the thing.
So Dr. Croker, how often should I have that blood work drawn?
So initially when you're increasing the dose, we actually do it weekly. And after that, we ask patients to do it monthly. So recently, we're actually conducting a study to see how often people have those elevated liver enzymes and things. And we actually say we usually only see them in the first year, but I think sometimes people will get them. And the trouble that people will get is they will get a viral infection, which will cause them to rise, or there could be other reasons. And so we actually look for a persistent hepatitis.
So you're looking for this change twofold above normal, but also something that persists.
Yep.
Yes. So another question is, this is a very good question, and we struggle with this every day. A patient of mine is having a flare of their disease, and should I start them on the corticosteroid, as you've indicated, before stool culture? Mm-hmm. So Dr. Dealman, do you want to advise what you would do in these cases?
Well, it all depends on the patient, how sick the patient is. If you have a patient who is really sick, and you feel like you want to do something quickly, and typically you get your stool culture. That's important, most important thing. You don't treat somebody with antibiotic before stool culture, because you might then miss your pathogens. We have a quick turnaround, for instance, in our hospital, that you get a stool culture done and you have the results the next day. So then you typically can wait 24 hours. If you feel that you don't really have that time, the patient is really sick, you can get the stool cultures, start the patient on something like broad-spectrum antibiotics, and then ciproflagyl, and then start the corticosteroids.
So in general, get your culture, get a C. difficile toxin assay, both of those things, and wait for the next day, get the answer back, and then start steroids.
That'd be the best approach.
That's the best approach. Yep. Okay. Another question from Red Deer says, I have a patient with left-sided colitis on an enema and both oral medications and prednisone. So Dr. Dielman taking all your medications, and we assume adequate doses here of the enema every night, taking the oral mesalamine at 4.8 grams a day, and not doing well.
So,
What do you start her with?
well, not doing well. First, it is already mentioned here that a patient is also on prednisone.
Yes?
So that's a scenario that is again the first thing to do. Make sure the patient doesn't have an intercurrent infection. So rule out, do your stool cultures, and if those are all negative, then you have a patient that we call a refractory osteocolitis. That patient, if you just by the nomenclature on this one, is actually at risk for losing a colon. A patient who is not doing well on prednisone and all these medications.
And what would you put them on next? What's your next drug?
Well, first of all, I think if the patient doesn't do well on prednisone and has significant symptoms, I will admit the patient in the hospital.
Okay.
And then the discussion becomes, and particularly if the patient has severe ulcerative colitis, you scope the patient and it looks like severe ulcerated disease, then you have...
But suppose it's more mild disease.
Okay.
Are you going to go to Imuran, an immunosuppressive agent, or anti-TNF?
So Imuran won't work in that situation. So it's a medication that will work in 2 to 3 months. So the patient in the long term may require Imuran, but it's not solving your problem at long term. If you have somebody on 40 milligrams of prednisone and it doesn't work, you have to give the patient IV
Right.
steroids.
So we're getting into the nuances. So someone's already on steroids, adequate doses, and is still sick. That's steroid refractory, and then you don't really have time for Imuran. You're going to need to move on to a biologic or do something more quicker.
Biologic, yeah.
If, on the other hand, they are healthy on high-dose steroids, then you can add your azathioprine and taper them down.
Yes.
Right.
But from the gist of the question, I get that the patient is not doing well, right?
Despite steroids.
Yeah.
Okay. Another question here. We're running into some time constraints, but we'll try and get through a few more. So I've had different opinions regarding antibiotics for IBD. Dr. Croker, should I use them or not?
So I think it depends on where your disease is. So colonic disease, actually often antibiotics can be additionally helpful in inducing remission. For small bowel disease, it's not usually that effective because it's not usually the bacteria doesn't play as big of a role. If people have perianal disease and Crohn's disease with fistulas and abscesses and things, then we do use antibiotics. So you have to think about what the type of disease you have, if it's Crohn's or UC, and if it's Crohn's, is it something that you think will respond in terms of an abscess or a fistula, then you always use it. And so I don't think we use it on all of our flaring IBD patients, but often with a flaring UC patient, we do use it. And we use with Cipro and Flagyl or amoxicillin clavulanate.
So antibiotics are best for colonic disease, perianal, fistulous disease. Last question here is a tough one. My patient with Crohn's disease, terminal ileal Crohn's disease, is now failing Humira adalimumab, has already failed Remicade and infliximab, is on maximum doses of Imuran and corticosteroids. Dr. Croker, the last word, what is the next step?
I never get the last word. So I guess the first thing is that it's really important that someone like this be...
I think you always get the last word, Dr. Croker.
And really important for you to stage the disease. And so it's someone like this, it depends on where their Crohn's disease is. And it depends on, because you actually failed both biologics before. So the only other options for you are possibly surgery or steady medications. And so at the University of Alberta and in other places, they actually run clinical trials where we look at new medications that might be used. And so that's where a place where somebody would need to be assessed. If people have a limited disease in, depending if we could cut out their disease or induce remission using surgery, that would also be an important consideration. So it's really important to know the type of disease and where it is for this Crohn's disease patient.
So surgery for this patient may be the next step.
Yeah.
And surgery can be a very good treatment for patients who require it.
Yeah.
Particularly for very limited disease.
Right.
Somebody has been going on and all these drugs and has very limited Crohn's disease just to take a surgical resection. And it could also
cut it out and start over.
And if particularly if it's stricturizing disease, if you have a stricture that doesn't respond to all these therapies.
Right.
So
that's a good segue into next month. Ladies and gentlemen, we will be talking about surgery and inflammatory bowel disease, and we'll cover topics of the type of surgery, when to do it, when to refer for surgery, and when surgery really is the best treatment for inflammatory bowel disease. So I want to bring this hour to the close. I want to thank Dr. Croker from the University of Alberta and Dr. Leo Daleman from also the University of Alberta. We've enjoyed being with you this afternoon. To remind you that this webcast will be rebroadcast at 8 p.m. tonight. This webcast is on for your viewing at www.ibdclinics.ca. That's www.ibdclinics.ca. So you can go there to watch it. If you have additional questions, you'll have an opportunity to enter them in, and we will answer them over time on our frequently asked questions on that website. So thank you very much for tuning in, and we look forward to seeing you next month when we discuss surgery and IBD. Thank you.